Hi, and welcome to the Grace Supportive Care webinar series. My name is Arjun Gupta, and today we'll be chatting about ascites, or fluid in the belly, in patients with cancer. Joining us today is Dr. Shaalan Beg, who is a faculty member at the UT Southwestern School of Medicine in Dallas, Texas. He's an expert in the treatment of gastrointestinal cancers. Welcome, Dr. Beg.
Thanks for having me.
So, Dr. Beg, we're chatting about ascites in patients with cancer. Can you tell our listeners and audience about what that means?
So simply put, ascites means that there is accumulation of fluid in the peritoneal cavity. So the way I like to think about it is our intestines, our abdominal organs are all held together with this saran wrap that goes around all the intestines and holds all our insides together. And sometimes there can be fluid that accumulates in that space, and that area has a pretty large capacity to hold large amounts of fluid, sometimes not uncommon to exceed 8, 9, 10 liters of fluid at a time. Usually patients present with swelling of the abdomen. And the scientific term for that fluid collection in the peritoneal space or in the abdominal cavity is ascites.
So to clarify, this fluid is not inside the stomach or not inside these hollow intestines, but actually in a sac surrounding that.
Correct.
And as an oncologist who's treating patients with cancer, do you see this only in patients with cancer, or can this occur in patients without cancer as well?
One of the largest non-cancer group who struggle with ascites are patients with cirrhosis or who have symptoms of liver failure. And patients who have different degrees of liver failure, and again, cirrhosis is scarring of the liver. So when the liver is scarring due to either alcohol use or in the United States, hepatitis C or from fatty liver, it can cause a scarring of the liver, which increases the pressure of within the abdominal cavity. So it makes it harder for the fluid to go through, which increases the pressure of the blood in the abdominal cavity, and that causes fluid to leak into the peritoneal space. So the largest group of patients, the non-cancer patients who have ascites, are probably patients who have some degree of liver cirrhosis, and it's usually those who have advanced stages of cirrhosis where we see it. And the other group would be cancer patients, where there are two groups of patients who can develop cirrhosis. One group of patients would be those where the lining of the abdominal cavity, what I described earlier, the saran wrap around the intestines, becomes involved with tumors. I like to think of that as a studding or salt and peppering of the entire abdominal cavity, and that prevents the body from being able to reabsorb the fluid naturally, and can even secrete more fluid and cause an accumulation of ascites. Oftentimes we see cancer cells in that fluid if we were to sample it. And the other group of patients, cancer patients who can develop ascites, are folks who have symptoms of liver failure because of the cancer involving the liver, again, leading to a mechanism where it's increasing the pressure either by involving the veins in the liver or the liver tissue itself.
And are there a particular group of cancer patients, especially patients that you see, who are more at risk of developing this ascites?
Yeah, so my clinical practice is mostly around GI cancer patients. I think any patient with a cancer in the abdomen can develop ascites if their peritoneum is involved with the tumor. I think statistically the most common cancers, one cancer that comes to mind that's not a GI cancer, but that would be ovarian cancer, very frequently can involve the peritoneum. But most of the other GI cancers can manifest with peritoneal disease, with the most common ones probably being colorectal and gastric cancers. But I have seen a fair amount of pancreatic cancer also involve the peritoneum and cause subsequent ascites. ascites. So really any cancer in the abdomen can develop ascites where it's a matter of how the cancer cells decided to spread, whether it's through the bloodstream or through this direct extension or seeding of the peritoneal space.
Perfect. And you said that patients will most often present with abdominal swelling, and this is because the fluid is accumulating in this cavity, potentially causing other symptoms like lack of appetite, pressing on the belly, not allowing people to eat as much, leading to nausea. Patients can even have weight loss despite this additional weight that they're putting on with the fluid due to reduced appetite and cachexia. Any other big symptoms that you look out for when you're taking a history or examining a patient?
I think all the symptoms that you described, and the other would be altered bowel habits, right? So constipation or alternating constipation, diarrhea, noisy abdominal sounds. This peritoneal involvement, not the ascites itself, but because the cancer can start involving the surface of the intestines as well, that can sometimes lead to the surface of the intestines becoming more sticky and preventing the normal passage of bowel contents and can lead to bowel obstruction sometimes. That would not always be associated with ascites, but patients who have an ascites because of cancer involvement that we would call a malignant ascites are at risk for malignant bowel obstruction, which can be fairly challenging to manage. And the list of symptoms that you described is pretty accurate. And again, these symptoms can be fairly debilitating. Think of a 75-year-old lady, who's already losing weight because of her cancer or because of loss of appetite, and now is 7, 8, 9 pounds heavier because of fluid that she's collected in her abdomen, making it harder to move and harder to ambulate, makes her feel full early so she can't eat as well as she would like. And managing these symptoms can be fairly challenging.
And when you're seeing a patient who's coming to you in clinic and saying that, hey, doc, I think that my belly is more swollen, you as an oncologist know that they have a form of advanced cancer, say advanced colon cancer, advanced pancreas cancer. What are you starting to think in clinic? Is this a diagnosis that you can make in clinic itself, or you're thinking of doing additional tests? How do you go about triaging these symptoms, if you will?
I think it starts with the history and see what the tempo has been for these symptoms when they started, what makes it better, what makes it worse. And the classic history for someone with ascites would be a gradual growth in their abdominal girth with time. But sometimes flatulence, like feeling more gassy, or symptoms of indigestion can also be described as bloating. So bloating is a fairly non-specific term. So my brain may not always jump to ascites if someone is describing bloating, but their history together with the exam to see whether on the exam there's appreciable fluid in the abdominal cavity, looking at their most recent scans to see if there was a hint of any fluid accumulation on their last scans, or if they have cancer that's spread that puts them at risk for developing a malignant ascites. So all those factors sort of add on to increase my suspicion. So for pancreatic cancer patients, sometimes if they have bloating and altered bowel movements, it could be a sign of pancreatic insufficiency, and we would treat that very differently than we would if it was ascites. So together with the history and our exam findings and the specific distribution of the cancer that the patient has, helps us decide if an ascites is at a high risk. Is the fluid buildup associated with other fluid accumulation, either under the skin or around the ankles? Do they have fluid buildup in other spaces, for example, in the chest, in the pleural cavity? We look at their labs. to make sure their protein numbers are okay. If we have enough of a suspicion, depending on how debilitating the symptoms are, I may order other tests to work that up, or just leave it at clinical suspicion and decide how to treat based on their symptoms.
And suppose someone has voluminous ascites that's really causing them discomfort. You'd mentioned earlier about there be potentially two causes of patients with cancer having this ascites: the spread to the liver or liver dysfunction, and spreading to the lining of the peritoneum or that saran wrap. Is there a way that you can differentiate that with an imaging test, or you'd mentioned sampling this fluid as well?
Scans the scans can tell you if if the radiologist thinks that this is a malignant ascites, but it's notoriously non-specific. I think the gold standard for seeing whether ascites is coming from a malignancy is to take a sample of fluid and spin it and look it under the microscope and see if you see cancer cells. And if you see cancer cells, then that's malignant ascites. And then the other group that we were discussing were folks who have portal hypertension or liver failure symptoms. Looking at their scans and see if they have any venous involvement, if what their albumin is like, what their child score is, can help us see which end of the spectrum they're falling into. And our hope is to always find those patients before the fluid becomes out of control and is causing too many compressive symptoms and difficulty breathing or laying flat or eating. And then based on whether we think it's malignant or non-malignant, really the first line of treatment to help control the ascites would be through diuretics, either same one diuretic or combination of diuretics, and to make sure we titrate that to a certain level and see if those numbers, whether those symptoms can get better. Historically, patients who have ascites because of portal hypertension or liver involvement, liver cirrhosis, tend to respond better than those who have a malignant ascites. Diuretics can help folks with malignant ascites. It's still my first line of defense to try and help control their fluid buildup. For malignant ascites, really the main treatment option is to help control the cancer, because their symptoms are getting worse because the tumor along the lining of the cancer is getting worse, and you need to treat that in order to help the normal flow of fluid to take place. So the treatment for malignant ascites, in my mind, would be treating the cancer. But if the diuretics don't work and treating the cancer isn't working, then the next step would be to physically drain the fluid by sticking a needle in the abdominal cavity and draining the fluid. And it's not uncommon for us to have to remove 3, 5, 8, 9, 10 liters sometimes in those patients, based on how long it's been going on for and what their body size was and all.
And so, just to summarize for our viewers, these diuretics are water pills that help us urinate out excess fluid that's accumulated in our body. And it may be helpful for some patients, especially with patients with liver dysfunction, and perhaps a subset of patients with malignant ascites. But ultimately, we want chemotherapy or another cancer-directed treatment to control the underlying cancer, which is leading to the malignant ascites. And then Dr. Beg, you said that if that's not really working out and patients have lots of symptoms, such as that swelling in the belly that's causing discomfort, that's perhaps even causing shortness of breath, you would consider taking out 5-10 liters of this fluid in a procedure called a paracentesis, which can be done every few days or weeks if that fluid is coming back. And this is often a simple procedure done at bedside. People can come into their urgent care or in their doctor's office and get this done. When you're seeing these patients in clinic, Dr. Beg, who are having this recurrent ascites, which is not being managed, how do you start to think about these patients, and what do you tell patients and caregivers?
So I think, first of all, recognizing that the burden of symptoms that they're having is tremendous is really important. Again, their mobility can be affected, their appetite can be affected, their mood, their morale can be affected with if their ascites is uncontrolled. If the ascites is a malignant ascites, so we think it's from cancer involving the peritoneum, my conversation is a little different in patients who are newly diagnosed and starting their treatment versus someone who's been on chemotherapy for a much longer time and their cancer has gotten worse on chemotherapy treatments and is now developing ascites. For folks whose cancers have not seen chemo treatments, we have the potential for controlling the cancer and therefore controlling the ascites. So I'm fairly confident in those folks that we can get a grasp of those symptoms for quite a while, and give them plenty of relief from their symptoms. But if we start seeing somebody who's been on chemotherapy or different lines of chemotherapy, so their chemotherapies become much more resistant and much more aggressive with time, and now they start developing ascites, I think that tells me that's just another sign of their cancer getting worse, as it is when we look at a lung spot get bigger in that group of patients. For those patients, oftentimes the diuretics are not as effective. Again, still my first go to see if we can help give them some relief with diuretics, so we can space out how frequently they need to have the paracentesis done, how frequently they need to have a needle drainage done for their fluid. But if they need to have the paracentesis done fairly frequently, and for me, having to do it more often than once a week is very burdensome for patients, can be very burdensome. For those patients, I would talk to them about considering a drain, where the radiologist can perform a bedside procedure, and after they drain the fluid, just after they stick a needle to drain the fluid, that they leave a catheter into the abdominal cavity, which sticks out of the body and lets the patients drain the fluid at their own pace at home whenever they feel that the symptoms are accumulating. Again, these are symptoms which can affect their appetite and affect their mobility. So trying to stay ahead of those symptoms is important, but that we don't want to remove too much fluid too quickly, because then we worry that we may make folks dehydrated. So it's trying to find that balance for that specific group of patients. But I try to keep the paracenteses as far apart as I can by giving additional adjunctive diuretics. But if we see that we're not able to do that, then the next step would be to have a catheter placed.
Perfect. So to summarize, these decisions are quite nuanced, especially in patients who have advanced cancer, who've been through a few lines of chemotherapy, and you're looking at various factors, and perhaps most important of which is what the patient and his or her caregivers might want, especially if the cancer is becoming more aggressive and perhaps does not have many treatment options. So whether patients would like to continue to come to the hospital to get these repeat paracentesis procedures, or perhaps prefer to spend more time at home in what could be a terminal condition.
So for the group of patients where we believe that the cancer may be in its terminal stages, having the conversation on whether a drain is appropriate is really important, especially if that patient and their family members are considering hospice as an option towards end of life. Oftentimes, it's a much smoother transition for patients if they have the catheter placed before they go on to hospice, so that the hospice agency and the family can care for that before after they go on to hospice, as opposed to having to try and have that placed after they've moved. But yeah, that's something to also think about in terms of timing and when we should consider that in the selected patients.
Perfect, Dr. Beg. That's all the time we have. Thank you so much for joining us. And I hope when we redo this webinar in 1 year, we'll have more effective therapies, more information to help our patients. Thank you.